everyone has enjoyed lunch, and welcome back to the afternoon session. Is an understatement for me to say it is a distinct pleasure to introduce my good friend and longtime colleague, Dr. Greg Yanik from the University of Michigan as the keynote speaker for today's terrific symposium. In a line, Greg is simply an outstanding physician, clinical investigator, and educator, and yes, even a better human being. Greg's a true Michigander. He was born and raised in the Detroit area, attended college at the University of Detroit, medical school at Wayne State University, and he did his med-peds residency at Beaumont Hospital before completing his fellowship training in hematology and oncology at Cincinnati Children's Hospital. Clearly homesick, he returned to the great state of Michigan in 1992 for his first faculty position in the Division of Pediatric Hematology, Oncology, and Bone Marrow Transplant at the none other than University of Michigan, and has been there ever since. I personally had the great pleasure of working and meeting Greg soon after my arrival to the U of M in 1999, and together we worked on bringing novel insights generated in my laboratory back to the clinic in the form of innovative trials to treat BMT patients with both acute and chronic lung injury. Now, these were some of the most exciting and rewarding times of my career, and some have suggested, Greg, that our interest in chronic GVHD, the lung, were way ahead of the curve. And judging by the incredible pharmaceutical interest in this space today, I think that is right on the money. Greg's academic achievements go well beyond lung injury after transplant. He's also made sentinel contributions developing novel transplant options for pediatric patients with a very common solid tumor known as neuroblastoma. He has over 150 publications and has co-authored numerous book chapters, many of which I am really excited to say we have co-authored together. His contributions to medical research have been recognized by several awards, including but not limited to the Leland and Elaine Blott Professorship in Pediatric Oncology at the University of Michigan, the University of Michigan Pediatric Teacher of the Year Award, and the Leukemia Lymphoma Society Chairman's Citation for Outstanding Service. On a personal level, Greg's a terrific friend, husband, father, and role model. He and his wife, Mary Beth, have 3 grown children, all of whom have pursued careers in medicine. And in his spare time, Dr. Yanik makes time to serve on the executive committee for Make-A-Wish, Michigan. Greg, there are not much more I can say other than to extend a very warm welcome to the keynote speaker address at the 2023 Cowden GVHD Symposium. Welcome.
Can everybody hear me? I may walk around. I like to walk when I talk, but it's truly a pleasure to be here. That quote, can everybody read the quote at the bottom of my introductory slide? The quote says it all. It talks about my relationship, not just with my colleagues, with Dr. Cook, back when we first met back in the late 90s at Michigan, with my patients and families there. But also talks about the joyful connection I made with Meredith, Jerry, her dad, Marty, her mother, back at the TCT meeting in February of this year when I first was introduced to Meredith and her family. And you know what, this meeting today, last night's dinner, I can't tell you how many joyful connections I've made myself. In fact, I made one today at 5:30 in the morning. Just standing outside. There is a young lady here named Jody, and she's here. She'll be receiving an award for patient advocacy today. She was here with her 2 grandsons. Her daughter died from complications of graft versus host disease. And while we were standing outside with the fire engines going past, we just got to talking. And then when the whole fire alarm thing ended, I just wanted to keep talking to Jody. So Jody, where are you? Right back there. Well, so to Jody, her family, to Meredith, to Jerry, to Marty, to all of you here, to all of you listening, I just want to thank you for the joyful connections. So, and with that, let's start. I actually want to start with The next slide comes from another good friend and colleague named Guangxing Cheng. She's a pulmonologist in Seattle. And she actually ran a patient forum group 9 months ago. And I asked her, how did it go? Well, she sent me an email with some of the quotes from some of the patients. They all had lung GVH. This is the email she sent me from 3 quotes from patients. I need to breathe to live, but I also need to live to breathe. I'm alive, but I've had so much loss. If I had known I would get lung disease like this, I would have rather had died from my AML. I saw that email from these patient quotes and I just dropped my head. I actually asked Guangxing if I could share these quotes because people out there that have had chronic GVH of the lungs, I'm sure they can feel every one of these quotes. So I just wanted to start with this. I wanted to bring this cartoon in because I think this cartoon says a lot. I don't know if you can read it. It's a boy riding a horse with the dog next to him. The boy says to the horse, what's the bravest thing you've ever said? Asked the boy. Help, said the horse. And thus, as we start this talk, it's a circle of help. The patients, all of you, the caregivers, you're looking to us, the clinicians, for help. We are looking to our research teams for help. The researchers that are here and nationally, they're looking back to all of you, the patients and caregivers, to help us with your research. And literally, it's a circle of help because we all need each other. So with that, how do we define lung GVH? Just simplistically, the lung manifestation, it's the lung manifestation of chronic GVHD. It's an obstructive airway disease that occurs roughly 3 to 24 months post-transplant. I often view lung GVH as it's the equivalent of emphysema, okay? It's transplant emphysema. At our center, the median onset's 325 days post-transplant. We've seen cases as early as 3 months up to 3 or 4 years out from transplant. We'll see it in 5 to 7% of all allogeneic transplant recipients. And in patients with chronic graft versus host disease, about 10 to 20% of all patients with chronic GVH will develop GVH of the lungs. The term for it, all of you, the physicians here know this term, bronchiolitis obliterans syndrome. I may use those terms interchangeably to the patients and caregivers listening today. In fact, I'll even explain what the terms mean in a second. So lung GVHD, where do we stand in 2023? That looks like my son driving. Good heavens. We often diagnose it too late. Our diagnostic criteria, I really feel this way, are strongly flawed. We have limited understanding of the pathophysiology and the biology of it. Defining response is difficult. I'll talk about this on another slide. We have few prospective therapy trials. And simply put, these are the challenges. This next slide is a little sobering. We've got a large database at the University of Michigan. We keep it prospectively. We've now got over 4,000 patients in this database with about 30,000 biosamples linked to them. So I went back and just pulled out our patients that had lung GVH or BOS between 2000 and 2018. And you can see that the median overall survival for this patient population is only 4 years. That's from the onset of their lung GVH at our center. This is single center data, but many other centers will show similar survival statistics. The good news is this data was compiled between 2000 and 2018. There's been, I would say, an expansive growth in knowledge over the last 5, 6 years in particular, with new diagnostic techniques that have come available to us, collaborative teams that are now, I'll talk about several today at the end of this talk, predictive biomarkers, novel clinical trials, but also your support. Just having folks like myself, like Dr. Cook, like all those wonderful talks I heard this morning, just having us being able to reach out to you and your support back for us, I would say is a huge plus. So for patients, caregivers, this is just a little primer on the pathology of lung GVHD. On the far left-hand side, let's see if I have a pointer here. Yeah. Let's see. There we go. So this is the lung. This is the normal lung. This is what we call this is the alveolus. So where air gets in, it's then transferred across into blood vessels to be picked up by our body. So it's called the alveolus or air sac. This right here is a small airway. The smallest airways are called bronchiole, and thus you can imagine this term bronchiolitis, inflammation of these small airways. You can imagine what obliterans means for bronchiolitis obliterans syndrome. You can see that over time, as the GVH progresses, this bronchiole starts getting thicker and thicker, and eventually looks like this. And this is the full-blown bronchiolitis obliterans syndrome. You can see the airway right here in the middle, literally completely obliterated now by this fibrogenic deposit that's surrounding it. Air can get trapped, air can get in, but it can't get back out. And thus, chronic GVH of the lungs, or lung GVH, is really an air trapping syndrome. The air gets stagnant. It's like stagnant water in a pond. Germs start developing in that situation. What I really like to think about it, though, and I stole this slide from Ken. Ken published this before, and I love this. Ken, I've adapted this for you. The stages of lung GVHD. And you recognize this, I'm sure, already, Ken. Right here for everybody watching, there's the airway again. This blue cells around it, these are white blood cells. These are lymphocytes, primarily T cells. T cells are what mediate a lot of our immune-mediated tissue injury. So you've got this circumferential layer of T cells around this airway. This is the start of lung GVH, acute lung inflammation. But it can occur in any number of ways. I always tell patients all roads can lead to Rome, meaning an infectious pneumonia, viral, bacterial, fungal, high-grade acute GVHD, transplant conditioning therapy that we give, Cytoxin, TBI, BCNU in patients with lymphomas, for example, sort of other transplant conditioning. Anything that causes damage around these bronchioles will cause an acute inflammation. Then if that inflammation stays there long enough, you start getting little bit by little bit, you can see layers of pink around the blue cells. You start getting fibrosis. This is a term, this is chronic inflammation. We call it chronic lymphocytic bronchitis. And then if this chronic inflammation goes on long enough, you just get these fibrotic airways. The point here is this, and it goes back, literally back to the last talk we heard on ocular disease too. Too often we're treating here, where we've got advanced stage fibrosis. A lot of our therapy should be here, where we still have a lot of lymphocytes, a lot of active inflammation. This stage that a lot of our immune suppressants, steroids and other immune suppressants, will still work. If you get back to this stage, now you need treatment choices not based on suppressing lymphocytes, but based on breaking down the fibrosis. We did an extensive study at our center. So again, this is single center data, but a lot of centers will have some permutations of this. We looked at factors that will predict who's going to get lung GVH. These are the ones we saw. And I'm going to spend a fair amount of time on going back and forth on this slide. Patients who had high-grade acute GVHD, grades 3 and 4, viral infections and/or pneumonia within the first 100 days post-transplant, and then the last two. The physicians will recognize these, but a lot of you listening to this talk are not physicians. So these terms will mean nothing to you. Low FEF 2575 pre-transplant, low FEV1 at day 100 after transplant. I'm actually going to give you a primer today so you can actually understand PFTs as patients and caregivers. Things that we didn't see impacting the incidence of lung GVH were gender, age, race, underlying disease, whether you got bone marrow, peripheral stem cells, the degree of HLA match, the conditioning regimen, low IgG levels. I will say that if you have a low IgG level or antibody level after you get chronic GVH, that will impact the incidence of getting lung GVH, but just having a low IgG level going into it didn't. So let's start with this one. Viral infections and/or pneumonia within the first 100 days post-transplant. Think about what I'm saying. The median time to onset of lung GVH And our center is 325 days, 1 year. So now I'm stating what happens if you get a viral infection. You can pick the virus, rhinovirus, COVID, RSV, CMV, just name the virus, both DNA and RNA viruses. And what's the impact on getting lung GVH? Well, we looked at 730 something patients at our center. My colleague Xiaofeng Zhao published this a couple of years ago. We examined the incidence of respiratory viral infections, or RVI, in the first 100 days post-transplant in all of our allotransplant recipients. And then we looked at those that developed an RVI with the subsequent development of lung GVH or not. And what you'll see here, this is years post-transplant on the x-axis, the probability of getting lung GVH on the y-axis here. Look at this group. It's actually double. The group that had an early post-transplant respiratory viral infection had a double, twice the incidence of getting lung GVH than those that didn't have an early viral infection post-transplant. Why? Again, because all roads lead to Rome. You start that acute inflammation with that viral infection. That acute inflammation leads to chronic inflammation. That chronic inflammation, now months to a year later, leads to a full-blown VOS or lung GVH. So I really want to place a lot of importance on this to patients, caregivers, people that are about to go through transplant. Be very wary about getting viral infections in that first 3 months post-transplant. How about these two? You know, I said that I'm going to have to teach you PFTs, and I will in a second. But this is a pre-transplant PFT value, meaning that at our center, we were able, in fact, these two right here, these two PFT parameters, had the highest prognostic significance for identifying who is going to get lung GVH at our center roughly a year later. And one of these parameters was obtained prior to transplant. I bet you every one of you here that's listening to this talk who's had a transplant probably never asked your physician going into transplant, what was your FEF 2575? I bet you not one of you asked at day 100, your transplant physician, what was your FEV1? After hearing what I'm about to say, you will now. Okay. So again, these are our two most important predictors for lung GVHD. So primer for understanding PFTs. For the patients, hopefully most of you, all of you have had PFTs at baseline and at some point post-transplant by now. You've seen the pulmonary function test. I've tried, I had to do it myself. Ken, have you ever done them, PFTs? God, I don't know how our patients can do it. For the patients that are here, you feel like you're blowing your brains out. You know, they just tell you, take a deep breath, exhale, exhale, keep blowing, 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 blowing. Good God, I don't know how the patients can do it. But you recognize the machines and what you have to go through. So these are the two main, again, this is for patients and the caregivers. These are the two main parameters that we as physicians look at. I'm now giving you insider trading information. I'm about to give you a third parameter in a second. FVC, forced vital capacity. It's the total volume of air that you can exhale from your lungs. FEV1, and this is the gold standard for us, is the forced expiratory volume of air in 1 second. This is the gold standard that we use for determining who has lung GVH or not. We start with FEV1. So it's again, the volume of air you can forcibly exhale in 1 second. What does this all mean in English? Well, let's start with this. On the left-hand side of this graph, you can see normal breathing. We call it tidal volume. Every one of us in this room right now, this is our normal breathing. We breathe in, we breathe out, we breathe in, we breathe out. It's just our resting breathing pattern. Now, when you undergo PFTs, this is what you see. You take a deep breath, as deep as you can, and now you breathe out as forcibly as you can, and you keep breathing out. You breathe out until you just keep breathing out until you can't breathe out anymore. This value right here, FEV1, measures the amount of air you can forcibly exhale in 1 second as you come down this line, this curve. FVC right here measures the amount of air that you can totally exhale from the start to the finish. By the way, right here is residual volume. Everybody here is aware of residual volume in one way or another, especially if you played sports. That's what happens when you get your wind knocked out of you. You know, if you've ever had your wind knocked out of you playing anything, what you did was you forcibly from your diaphragm knocked out all of your residual volume, and you literally have that air hunger. That air hunger starts when you fill back up your residual volume, okay? So these are the two main parameters we measure, FEV1, how much air can you exhale in 1 second, and the total amount of air you can exhale. I'm going to recommend looking at a third parameter, and this is the one that I said had prognostic significance pre-transplant, FEF 2575. This stands for forced mid-expiratory flow rate. It's the amount of air that you can forcibly exhale 25 to 75% of the way through exhalation. Well, this test is really sensitive for detecting the first initial signs of airway obstruction, even before your FEV1 drops. It often declines, as I say, prior to the FEV1. Unlike the FEV1 measurement, you can't cheat the test. And here's what I mean. Every one of you, take a deep breath right now. All right, breathe out as hard as you can. All right, so you can cheat the test with an FEV1. How much air can you exhale in 1 second just by going like this? Well, it's not a lot because I didn't take a deep breath. But I want every one of you to take a deep breath and now try stopping your exhalation 25% of the way through exhalation. You can't. Once you start breathing out, it keeps coming out. So FEF 2575 is a predominantly effort-independent test. That's why it's such a sensitive indicator for airflow obstruction. So I'm now, for patients and caregivers, I'm now letting you into insight for what we as physicians look at when we look at your PFTs. Everything's done as a percent predicted value by age, by body size, weight, height, gender even. So you get a percent predicted value. You can just, let's say normal is around 100% of predicted for your age and body size, okay? And now you can start asking your physicians. By the way, here's what FEF 2575 is. It's right there. It's the air force that you have 25 to 75% of the way going down this curve. So now, after hearing this, as patients, caregivers, ask your MDs for your FEV1. Ask them for your FEF 2575. Ask them if it's declining. They'll shake their heads wondering, why are you asking us this? And you can say, now because you have insider trading information, okay? And when these numbers start getting under 75%, you're no longer in the normal range, okay? These are the NIH consensus criteria for how we define as physicians lung GVH. They were initially defined by Lisa Filipovich in 2005 and then updated by Madan Jageja at Vanderbilt in 2015. You can see the four main parameters right there, but they're really PFT based. There's an issue with this though, because right there it says FEV1 less than 75%, that you're then diagnosed with, you meet criteria 1 for lung GVH. That implies that getting lung GVH is binary. If you're at 76%, you don't have it. No, this parameter is already false. You're already going downhill when you go from 100 to 95 to 90 to 80 to 76 to 75%. It's not a binary number, a real thing, as you'll see in a couple slides to follow. No active infection. In order to be diagnosed with lung GVH, you have to have no signs of active infection. Ken and I published this several years ago. We did a study where all of the patients had to have a bronchoscopy at the time of study enrollment. We're actually treating them with a drug called etanercept. We enrolled 57 patients. All 57 patients did not act sick, but we knew that they met the criteria for lung GVH. 20 of those 57, so you're looking at roughly almost 35, 40%, had a discernible pathogen on their BAL. And they were walking around feeling just fine. Meaning that this criteria to have no active infection, well, in 40% of roughly 40% of patients, 40% of patients with chronic GVH are walking around with active infections in their lungs and they don't even know it. Why? Because the air is getting trapped. The germs are getting trapped, it can't get back out. What was the predominant organism we saw? Fungal. Fungal accounted for nearly 15 of those 20 cases. The NIH criteria fail children in whom PFT are difficult to perform. For those of you that are parents, it's difficult enough to get kids to eat their dinner, let alone to get them to do PFTs. Okay. All right, this slide looks incredibly complex, but it's not as complex as you may seem. Lung GVHD were myopic. The decline occurs much earlier than the diagnosis. So this is a study from, again, from Guangxing Cheng. She tracked 172 patients that developed lung GVH or BOS. All these black lines are just their FEV1 measurements for all. Each line, individual line, is a patient's PFTs done longitudinally over time. And she just put them all together on this, what we call a spaghetti plot. And then she took the average in the blue line. So the NIH criteria that I showed you on the last slide for chronic GVH, for lung GVHD, were met right where that red arrow shows. In fact, you'll see right here, that's days from onset of from diagnosis of BOS, day 0 right there. If you come across, you can see that the median FEV1 was already about 50%. That means that by the time the lung GVH was diagnosed, people had already lost half of their function. The problem is this, is that the steep decline occurs prior to diagnosis. We weren't diagnosing these patients until they were already at the bottom of that blue line. We needed to be diagnosing these patients as they were going down that slippery slope, and we weren't. This slide, I would say, is probably the most sobering slide of this entire talk. We published this at our center several years ago, and we looked at survival from patients who developed lung GVH or BOS based on what their FEV1 was at the time that we diagnosed them with lung GVH. What you'll see here is that for those patients who had an FEV1, by the way, if you remember that slide 2 slides ago, FEV1 less than 75%, that puts you into that lung GVH criteria. So for patients who were 60 to 75% at the time we diagnosed them, you can see their survival out almost 10 years. For patients whose FEV1 was in the 40s to 60s at the time we made the diagnosis, you can see their overall survival here. And worse yet, if they were already below 40% when we made the diagnosis, you can see the survival. Well, if that looks sobering enough, what was the median FEV1 when we diagnosed it at our center, where we actually look for this all the time? 57%. So even at a center that is looking at this, the average patient that we made the diagnosis on was on the blue line. The problem is that we start treating here. We need to be treating here. We need to recognize who's at risk here. And this slide, in my mind, says it all. Any talk should have a quote from Woody Allen in it, all right? The quote, 85% of success is just showing up. So the recommendations for how often should PFTs be monitored, just show up, just get PFTs done. This is the NIH criteria from 2014. This is what's recommended, that PFTs should be done at baseline pre-transplant, then at 3 months, 12 months, 18 months, and 24 months. Once chronic GVHD is diagnosis, they just recommended, quote, more frequent PFTs. They didn't even specify it. In 2020, Carrie Kitko from Vanderbilt led a NIH consensus development project, and it was just published a couple of years ago. These are the new PFT recommendations. For the physicians that are listening to this talk, I actually ask you, A, how many of you even know about this publication? And B, how many of you are actually following these guidelines? For the patients and their caregivers that are listening to this talk, how many of you are actually getting PFTs that match these guidelines? PFT is obtained every 3 months for the first year after transplant, and then once, or if chronic GVHD is diagnosed, having PFTs continuing to be performed every 3 months. My guess is, if I just polled the people in this room, the number of people that are following these guidelines and the number of patients that are following these guidelines is 0%. Okay. You've got one? Are you following the guidelines? I love it. All right. So I stand corrected. Are there any alternatives to standard PFTs? PFTs are difficult to perform for patients. Here's one. Again, I'll go back to Guangxing Cheng. She's a pulmonologist in Seattle. Guangxing has an R01 NIH-funded study that we do handheld spirometry. You can actually see the device right here. It fits in your hand. The patients can do it. Right now, we have the patients doing it weekly. Heck, you could do it every hour if you wanted to. It's a wireless Bluetooth-enabled device. The readings sync with your smartphone. So patients will literally see their FVC, FEV1. Now that you know what FEV1 actually means, you can actually see it right there on your iPhone. So it downloads on your iPhone, and then it downloads with our database automatically too. We actually don't even have to look at our database, because as soon as there's a 5 or 10% drop in your prior FEV1 reading, lights start flashing on our database so that we see it and pick it up. And then we start talking to your transplant physician that, hey, Jim Smith has had a decline on their handheld spirometry. The readings are transmitted electronically to the physicians. And right now there's a large 4-center study in progress. It's almost 300 patient study involving Seattle, Stanford, MD Anderson, and our center at the University of Michigan. I'm sure we'd be looking at other centers if people are interested. I'm also, I was talking to folks at Sanofi today to see if we can even get handheld spirometers for our patients to use outside of even this study. Imagine if you could do PFTs at home without having to do them on a machine. This is some of the printouts that you see from the handheld spirometry. You see both the FVC and the FEV1. And literally, you can see on these patients' values how the green lines and the orange line were declining over about a 6-month period of time. Problem is, we get PFTs about every 6 to 12 months. These things would have declined greatly, and we would have never even seen it. With the handheld spirometry, we can pick it up quickly. How sensitive are CT scans for detecting GVH? Well, high-resolution CT scans where you get inspiratory and expiratory images are the standard. They're sensitive, but they lack specificity. By the time that you see significant diagnostic changes on CT, such as what you see here, we call this bronchiectasis, where you see all this dilation of the bronchioles, the disease is often in its later stages. Earlier CT changes are just not that sensitive or specific. This is clearly diagnostic for lung GVH, but by the time you get this, you're already having an FEV1 that's pretty low. So I want to talk today, several of you know about our work at the University of Michigan doing a thing called parametric response mapping. Many of you are about to hear about this more and more as it becomes more universally used around the country. So parametric response mapping is a voxel-based mapping of lungs. What this means in English is this. Voxels are the 3D equivalent of a pixel. Pixels you see on a TV screen. So voxels are a cubic pixel. So we can actually divide the lungs into 10 voxels, 100 voxels, 1,000,000 voxels. And then we'll actually do what we call attenuation mapping. It's really just a density mapping of a voxel on inspiration, and we match it up with that same voxel on expiration. It means a computer program to overlay these voxels. And now we know what the density differences should be between inspiration and expiration, and we can color code them. So it requires a biphasic CT, meaning you have to get both inspiratory and expiratory views. My colleague Craig Galvin first reported in COPD or emphysema 12 years ago, and then Craig and I reported it in transplant back in 2014. We color code everything based on these density variants in the voxels. Green is normal, yellow shows areas of air trapping, i.e. lung GVHD. I'll show you an example of how this impacted a patient. Here's a patient who was 1 year post-transplant, so a 30-year-old adult. His CAT scan, he was already starting to feel a little short of breath. We did a CT on him. The CT was normal, but he was mildly symptomatic. His PFTs are still normal. And then we just did this PRM on him. You can see there's a lot of yellow in this already, even though we had normal PFTs and a normal CT. 2 years post-transplant, he now met the NIH criteria for BOS. Well, by the time he had that, his lungs are pretty much all yellow. He was already past the point of even treatable return. 5 years post-transplant, when we did a lung transplant on him, now you can see all this red. Red means severe emphysematous changes developing. The point being is that this technology is so sensitive that we can pick up these yellow changes even before PFTs or even standard CT often can. So the utility of parametric response mapping, by the way, the technology is commercially available by IMBio, IMBIO. We have an upgraded version of it at our center. We're running a large NIH-funded study on it, but all of you can get it done at your centers if you just license with IMBio. Uh, you can quantify it. You can quantify the voxels to monitor response to therapy. You can see the lungs. We'll actually do 3D views of the lungs with all the colors, so we can get a spatial view of the lungs to help guide biopsies. And it's effort independent. So for children that can't do PFTs, we could use PRM as a way to look at how much airflow obstruction do they have. And then I just want to talk a little bit about the therapy for lung GVHD. I just want to quote one of my colleagues, because this quote says it all for the physicians. Think about this quote, because it is why we practice. We make a lot of our decisions based upon anecdotal experience, a paucity of data, and then we extrapolate from there. All right. I've done this once. It's not quite the same, but let's do it this way again. And that's our therapy in many ways for lung GVHD. Currently, therapy is based upon consensus opinion. There's few randomized trials. Few of the trials were prospective. Several prospective trials that have actually impacted care. One was Anne Bergeron's study with inhaled corticosteroids. It's a small study, less than 20 patients, I believe. But it's become the gold standard. It's why a lot of our patients now use inhaled steroids. Kirsten Williams' study with FAM therapy, fluticasone, azithromycin, and montelukast. A lot of you with lung GVH, I'm sure, are on FAM therapy. Kirsten published this several years ago. And then Ken and my study with etanercept was actually a prospective trial. And I bring this trial up for a couple of reasons, because all three faced a response conundrum. And this is an important thing for patients and caregivers to appreciate, this response conundrum. The response criteria for lung GVH, how we do a trial and measure, is it actually working? It's really ill-defined. We can measure it by stabilization of FEV1, meaning you started with an FEV1 of 50%. We treated you for a year. At that end of that year, was your FEV1 still 50%? We're not looking to see if it increased, just was it stable? Well, in Kirsten's study that we now use FAM from, she was just looking at a 3-month stability at FEV1. She wasn't even looking at 6-month or 12-month stability. I would actually say you should look for an improvement in FEV1. If a therapy is working, that FEV1 should improve. By what amount? 10%, 20%? How about other parameters? Quality of life, walking speed, overall survival? Well, the etanercept trial, the third trial that Ken and I showed, or Ken and I did, we actually defined response as a 10% increase in FEV1. This trial has one of the largest response rates for BOS reported to date. 30% of our patients we treated had a 10% or more increase in FEV1. Ken and I were ecstatic. I mean, this sounded like maybe not a home run, but at least a double for our patients, except for one thing. Not one responders on our QOL measurements had an improvement. What that told me is maybe we've got the wrong response marker. If our therapy is really working, our patients should feel better. Maybe Ken and I needed to pick a 20% improvement, a 30%. We don't actually even know what that response marker should be. It probably should be quality of life. Here's some of the trials for lung GVHD that are right now on clinicaltrials.gov. Steve Pavletis right here is doing a trial with the neutrophil elastase inhibitor. And Steve, I think you told me it's in the second stages or phase 2 portion of it right now. Amina Lucy at MD Anderson is running a trial with a second generation JAK inhibitor called itacitinib. Joe Su at Stanford just finished a pirfenidone trial. This is a TGF beta inhibitor that he actually gave targeting patients that actually had the fibrotic form of lung GVH with some really intriguing results. There's a group in Switzerland doing aerosolized cyclosporin. Christian Hawk in Switzerland is using nintedanib, which is a second generation TGF beta inhibitor right now. Zach D. Philippe at Mass General, Cass Myers in Cincinnati are both doing trials using Jakafi or ruxolitinib to treat lung GVH. And Corey Cutler at Dana-Farber is using belumosudil or Regirock to treat lung GVH. This is what's out there right now on clinicaltrials.gov. If you add up the number of studies, you're looking at 7. I think there's room for a lot more. Any talk that can quote Yogi Berra, I also appreciate too. The future isn't what it used to be. So right now I'm going to show you some of the NIH-sponsored projects. And I have to start by just telling investigators, I probably don't have them all. So these are just ones I know that are looking at lung GVH. Ajay Shashadri at MD Anderson is looking at nasal absorption studies, microbiome in the nasal tract, oral microbiome studies. really elegant biomarkers work. David O'Dwyer at our center is looking at oral microbiome. Matt Zinter at UCSF is looking at lung microbiome studies. Bruce Blazer at Minnesota, the team at Dana-Farber have a lung organoid model that they're looking at for lung GVH. Guangxing Ching has her R01 funded high and health spirometry study. Ken, you've done a lot of work with endothelial injury models, but it's principally looking at pulmonary vascular injury and BOS, and Ken's NIH funded for that. My work with Craig Galvin to my left with our parametric response mapping. Laura Walkup using this really novel MRI technique called hyperfractionated xenon MRI in Cincinnati, and then Stella Davies at Cincinnati and Sam Goldfarb at Minnesota with a study called Transpire. I just want to highlight these two because these two studies are focusing on peds. Only 16%, in a publication came from Jeff Cuvalier not too long ago, only 16% of pediatric patients who were diagnosed with lung GVH were diagnosed while they were alive. That means that 84% of pediatric patients diagnosed with lung GVH were diagnosed on autopsy. That means that we're failing the diagnosis in kids. So Stella Davies, Sam Goldfarb, Laura Walkup actually have a large study now, a prospective study that's going to enroll almost 2,000 pediatric patients and prospectively tracking their PFTs, doing this Xenon 129 MRI imaging. This will be the largest pediatric PFT study ever. Our group at U of M, partnering with Ajay Shashadri at MD Anderson, Guangxing in Seattle, we've now combined with multiple R01s and are all kind of pulling our resources together. I wanted to just show the last couple slides and end it here. But therapy, the power of exercise. What you see here on the left-hand side is an actual PFT from a patient. I'll just give them the first initial T. What you'll see here is T's FEV1 is 52%. DLCO, the physicians know what it means. It's our diffusion capacity. What's the likelihood that the air we breathe actually gets across our lungs, through our blood vessels, and out into our bloodstream for that oxygen to be taken up and taken to parts of the body? So DLCO is a measure of how well can oxygen and air in general be diffused into our body. Well, this is 107% of predicted. I asked T, I said, when did you start biking? By the way, he's biking 30 to 40 miles a day when he did these PFTs. He said he never felt better. So he said, I started biking 5 years ago. So when I looked at his PFTs back then, his FEV1 before he started biking was 58%. He's actually lost 6% on his FEV1, even though he's been biking 30 to 40 miles a day. What he did do, though, is increase his DLCO, his ability to transport air and gas and oxygen from his lungs into his body by 30%. For those of you wondering what you can do to help improve your lungs, the power of exercise, as evidenced by these PFTs, is just astounding. This guy feels great, riding 30 to 40 miles a day with an FEV1 of 52%. As physicians, we must develop shared databases. We must develop common biomarkers of lung, blood, imaging scans. We must develop common protocol endpoints. Right now, we can't even compare studies because we all have different endpoints. We need to partner with you. We need to partner with pharma. We can't go this alone. It's a circle of help. We need everyone's help. In conclusion, the lines between infections and lung GVH are blurred. Early onset viral infections increase the risk of lung GVHD. Many patients with lung GVHD have infections and don't even know it. Lung GVHD, the diagnosis must be made early, prior to getting irreversible lung damage. Handheld spirometry, PRM, those hyperfractionated MRI scans all hold promise. We need randomized clinical trials. We need common response criteria. But really, to quote Woody Allen again, 85% of success is just showing up. We need to get PFTs done in a regimented fashion. So I want to end by thanking Meredith, her family, and the Meredith Cowden Foundation. I also want to thank the patients, all of you listening to this, the patients we serve, the medical teams we work with, and to all of you here and online. That quote, happy are those who dream dreams and have paid the price to make them come true. Many of you listening as patients have paid the price with what you've gone through. I just hope that you'll reach that happiness in your dreams. By the way, that picture on the far right, that's just cheap advertisement. That's my first grandchild. That's Eliza Catherine with my son. Thank you.
Greg, that was just terrific as I anticipated. I know we're a little short on time, but I would love to take a couple of questions for the audience.
Yeah, that was a great talk, Ron Sobix of the Cleveland Clinic. I just, with that data that you mentioned about with the early infections and with the COVID pandemic particularly, wasn't sure, obviously, some of this is still folding out, but what you anticipate or you have data with regards to those with COVID pre-transplant, how that might impact things down the road?
No, it's a good question. In fact, you could actually ask, are you seeing a difference in incidence of lung GVH based on if you're getting an RNA virus, which is what COVID is, versus a DNA virus like CMV? No, we feel that both give you an increased incidence of lung GVH. In terms of COVID right now, the answer is yes, though we're all seeing it right now, Ron, just as it's happening. So we're starting to see a much higher incidence of lung GVH in our patients now. At our center, we definitely will be reporting this in the next year or two, instance of getting lung GVH in patients that had COVID infections during the pandemic. The answer is yes.
Other questions?
Yes, Jody. Jody can say 97% of people had
97% of the people in our BOS group had previously had RSV.
ugh.
My daughter did within the first 3 months.
Ugh, yeah, and you're now hearing me give you actual data that a RSV type infection the first 3 months and the downstream effects.
Yeah, that really hit home.
Right.
Perhaps one last question or two? I got it. Might trip over the wires over here.
Greg, nice talk. Would you mind talking just a little bit about the relationship of COP and lung GVHD? I think that's something that confuses a lot of us.
So the question for Marie is the relationship between COP, which stands for cryptogenic organizing pneumonia, and lung GVH. You know, Marie, you could view COP, lung GVH is a catch-all term. Ken hasn't even asked me about it yet, but lung GVH is more than just an obstructive lung disease. It can also be a restrictive lung disease. It can also include COP, or cryptogenic organizing pneumonia. Cryptogenic organizing pneumonia occurs, I view it, Marie, as a amalgam of both acute GVH in the lungs and chronic GVH in the lungs. It typically occurs in our patient population between 3 and 6 months out from transplant, whereas our classic BOS usually occurs between 6 and 24 months out from transplant. And usually we'll see peripheral infiltrates in these patients, almost an alveolitis. It does respond actually to steroids and etanercept too, like we'll see with our BOS patients if you catch it early. I just view it as a COP, as a kind of a composite between acute and chronic lung GVH occurring in that 3 to 6 month time period with this diffuse alveolitis. It's non-infectious, associated with secondary infections. So I view it in that constellation of lung GVH. I really should have put a slide, Marie, that just said lung GVH, BOS, restrictive disease, and COP. In fact, I should do that if I had to give this talk again. So
Perhaps one last question. Did you?
Hi, I'm Christina from Cleveland Clinic. I had a question if you have thought about ways to decrease the inflammation during those first 100 days if they were to get an upper respiratory infection as sort of a preventative, maybe like a Madril pack or something similar.
yeah, it's a good question. We have not looked at it yet to see if patients who had respiratory viral infections the first 100 days, if they're treated with steroids during that period of time for anything, what happened to them. We just haven't done that analysis. But your question is right. We're now looking at things. The physicians are about to hear this for the first time. We're looking at doing aerosolized inhaled treatments during that first 100 days for patients that have early onset RVIs. Steve, you may find this interesting. We're looking at aerosolized AAT, alpha-1 antitrypsin. Steve's work with Avelostat, it kind of works on a similar philosophy. So we've got a PharmD at our center that we're working with to try to aerosolize medications so that you get these early onset respiratory viral infections. And we're looking at then at clinical trials giving you a novel inhalant, more than just inhaled steroids, to try to suppress that acute inflammation. But it may be that just simply putting you on inhaled steroids may be the answer too. So,
Hey, Ken.
Excellent.
Sorry, Ken, I'm gonna steal from you for a second.
Hi, everyone. Kemi Oshandina from Santa Fe. I just wanted to answer Jody's question previously and comment. There are vaccines approved now for RSV for infants and older adults. So remember that, and hopefully that'll help a little bit.
yeah, we've actually talked, it's a great point. We've actually talked about giving RSV vaccines to all of our patients coming into transplant, or potentially even their donors so that they can pass on passively a high titer to their recipients.
Terrific. Greg, thank you so much again for making it out and giving that terrific talk. Jerry, I hand it back over to you.